Now it has come. Yeah.
Live on
Yeah.
YouTube.
Yeah. Okay, we'll start.
Yeah, so after Dr. Mohanty's opening comments, Suri, you have to give a 5 to 7 minutes on the critical concepts.
Yeah.
And then Dr. Rajiv Sharma, and then Amar. And
Okay.
then we have the flow as I've just put in our group.
Okay.
We have 1 minute to go.
Yeah.
Yes. Just look at.
Okay, now you mute everybody.
Yeah,
Except me.
everybody should be muted.
Except me right now. Okay.
That's right.
Okay. So should we start?
Yep.
Okay. Good evening to you all. Welcome to the webinar of Indian Arthroplasty Association. And as you know that this Indian Arthroplasty Association was started in 1995, and now we have completed 25 years. So this is the silver jubilee year of Indian Arthroplasty Association. I, being the president of this association, I invite you all to this webinar today. And this year being the pandemic year, we are now streaming this webinar every weekly, and from next month onwards, probably we'll do it every 2 weekly. Please go through our website, that is www.indianarthroplastyassociation.com, and please offer your suggestions in indianarthroplasty@gmail.com or to my personal email ID, that is drshsmanti@hotmail.com. Now, this webinar is being streamed live in the YouTube, and that is the channel, the YouTube channel. That is a link, and we have given the link. You must be seeing through the YouTube channel. And in addition to that, now we have created Facebook page. So you can like this Facebook page so that automatically you get a notification when we are live, or you can click, the link below like this in order to go directly to the Facebook in order to see that. So we are streaming both ways in the YouTube as well as on the Facebook right now. This is the 4th webinar in the series, and today this webinar is focused on the adult dysplasia hip reconstruction role. And we'll be talking everything about it, right from the anatomy till about the complex reconstructions. And today we have our guest faculty, Dr. Amar Ranawat from Hospital for Special Surgery, New York. And Amar is not unknown to all of us. He's attending orthopedic surgeon at HSS, New York, as well as professor of clinical orthopedic surgery at Weill Cornell Medical College, attending orthopedic surgeon at New York Presbyterian Hospital as well. And as you know, that he is the co-chairman now for the Ranawat Orthopedic Conference, which is held every year in the January in the different cities of India. I welcome you, Amar, to this webinar today, and thank you very much for devoting time for this webinar. This is Amar's recent photo, and this was a little earlier, probably when he was doing fellowship. Now, just 2 slides to show that many of our residents always ask about this 50%, 70%, what is type 1, type 2. And just to show, this is an X-ray of the dysplastic hip, and right side is affected, left side is normal. So you draw this line, this is the interteardrop line, and this is the vertical distance which is measured from the medial neck head junction to this interteardrop line. Then you measure the vertical diameter of the normal side head and see that what percentage of this distance as compared to the vertical diameter of the head. If it is less than 50%, it is type 1. It is 50 to 75% in type 2, 75% to 100% type 3, and more than 100% it is type 4. That is the Crowe classification. But the confusion arises when there is bilateral involvement. When there is a bilateral involvement, measure the height of the pelvis right from the iliac crest to the ischial tuberosity, and 20% of the height of the pelvis is taken at the vertical diameter of the head. Next, again, you draw the interteardrop line and measure the vertical distance of the head neck junction at the medial side from this interteardrop line on both the sides. And again, you see that what percentage is this compared to the 20% of this pelvic height. So it appears to that on the right side, probably it is a type 3, Crowe type 3, and left side Crowe type 2. Now, dear friends, today the convener is Dr. Anup Jurani from Jaipur. He is the past president of Indian Arthroplasty Association and had organized a beautiful conference at Nemrana Port 2 years back. And little housekeeping rules, may I request all the panelists, the faculty here, whenever you want to speak, just point your finger and Anup will allow you to speak. Before that, please do not talk, otherwise there is overlapping of the talks and that creates confusion for our viewers. Or if Anup feels that due to shortage of time he doesn't allow, then you can type in the chat box, then we can just project it whenever we feel comfortable. Now it is over to you, Anup, and I wish a fantastic webinar today. Thank you, everybody.
Yes, thank you, Dr. Mohanty, and welcome all to this webinar symposium on total hip for dysplasia. And let's set the ball rolling by inviting Dr. Surya Narayan from Chennai, who's also our guest today. And Suri, over to you to open the Pandora's box of dysplasia. Suri, you have to unmute. Suri needs to unmute.
Am I audible now?
Yes, yes, sir. Yes.
Yeah.
Yes, please. Yes.
On the screen is fine.
Yes, sir. It is.
Yeah. Thanks, Anup. Thanks, Mohanty, for this invite. I think indeed a pleasure to be around and then talking subject. It's been a while since I've been around, slowly limping back to what it used to be. Yeah, the subject given to me for the next 5 minutes was to just talk about hip dysplasia, opening the Pandora's box. To me, just first thing that came like was it the Rubik's Cube. How do we put the cubes in alignment and what do we get out of it? Actually, if we divide the issues into multiple facets, we do have some sort of a very sound understanding of all the aspects that's involved. And once you put everything together, probably you have the final solution. So probably that would be the way to go in understanding what is dysplasia, because total hip basic principles have been well established. So when we talk of like Mohanty put up the pictures, the moment these sort of X-rays and images come in, the first question, what is the implant of choice? What are the exposure issues and difficulties? Where do I get in the socket? Do I need a graft? So have been the very common questions we have been debating over time and over again. Some fundamentals have never changed. That's one thing very true. But the concepts do sort of modify itself, change itself, so long as we get, as and when we get this long-term data, like Amar is going to share with us this afternoon. So when you have this sort of sockets in varying, I mean, this dysplasias basically give you sockets in various alignments, various positions. Primary issues are that the head is at varying heights. You need to restore, especially if it is unilateral, varying amounts of lateralization, issues with the offsets, and various amounts of dysplasia, and you have bizarre shapes sometimes. So these are the issues, what differs from a conventional hip and what we try to understand. So to that point, I think probably it may be quite prudent to go back a few minutes or a couple of slides into what is the development of the acetabulum, because probably that will give us a certain amount of insights into why we see what we see. So if you understand the pathoanatomy, probably that also gives you a better approach to understanding this subject. And once you understand, easy to plan, execute, and restore the hip which you want. For example, also at the same time, one point I would like to maintain in our sort of a situation, dysplasias is fine. You often see these dysplastic situations. Sometimes these old septic hips, which have been dislocated right from almost the first year of life, also present almost like a dysplastic situation. They truly may not be a septic hip. If you look at it here, the acetabulum is absolutely looking a normal developed acetabulum. And you know that there's something more to it and not a true dysplasia in these cases. So if you see the anatomic development just for 30 seconds, it's a coordinated growth of both the socket and the head. Always remember, the head needs the socket needs the head to get a congruent acetabular shape. And the shape of the acetabular cartilage enlarge, which probably initially forms basically a cartilage source, is basically influenced by the contact articulation of the head apophysis. So if the head is well reduced in the socket, like if you see in this X-ray, you find when it is lateral, if you see the acetabular lateral angle, it is much higher. The moment the head is put down inside the socket, you find that the head is the acetabulum is forming. So till about 3 to 4 years of age, I think the cartilage has the capacity to mold, and that is what needs to be taken into consideration. And when we talk of this dynamic endochondral ossification that happens over the period of your childhood, if you see that this cartilage analog, this involves two basically epiphyseal points of the growth nuclei. One is the os acetabuli and the triradiate cartilage. This triradiate cartilage essentially helps you in sort of a radial expansion of the socket. That's what gives you the depth of the acetabulum over a period of time. And the triradiate cartilage at the top, what happens is that if it has constant pressure, if the development is not there, it tends to ossify, and then it tends to have sort of permanency. Beyond a point, this modification cannot happen. The enlarge on the top, the triradiate inside our cartilage, and this sort of calcifies. Over 4 to 12 years, the epiphysis slowly starts calcifying, and by about 12 years, if you see, the thing is ossified to maturity, and then is the radial expansion till the closure of the triradiate cartilage. So dysplasias can come, suppose if you have sort of a loading which is totally out, the acetabulum just retains the shape, it is extremely hypoplastic, you find a small hole when you open it. But if you have sort of a lateral articulation, then the thrust essentially is on the lateral superior corner, and this area has developed secondary injuries. So there is an improper molding due to the improper femoral load, and this is by far the most common mechanism used. First will be the damage to the labral cartilage. Second is also the lateral epiphysic nucleus. And if it calcifies, it tends to go vertical. The higher it is, the more vertical it happens. So you may find some pictures like this, basically because of the extreme lateralization and the lateral femorotibial contact with the cartilage. The adult characteristics then depends upon the stage of development at the time of this insult. If suppose it has happened very early, you find more drastic. If it has come a little later or untreated, sometimes it's partially treated, attempt at containment osteotomies or containment procedures. And if it is not right, I think then you get this problem. Some another few important points you should remember when you think and talk about dysplasia is femoral articulation and weight bearing over a pattern of time defines the best bone in acetabulum. It's a simple basic Wolff's law. The moment you have weight, the bone modifies, the bone hypertrophies, the bone sclerosis. The classical pictures. We always talk of this sort of a coronal projection, but imagine even the sagittal projection, depending upon the neck orientation, that will also influence upon the AP dimension of the socket. So that is a factor when we talk of the looking at the femoral version, the way it contributes to the impact upon what is the final shape of the socket which you will have. So shape of the head, again, is a good guide to the depth and the socket thickness. Imagine when you study the X-ray preoperatively or with the CT scans, imagine these are very useful tools to this. So if you look at acetabulum in dysplasia, which it has been studied, it is basically a long axis and it's an oval acetabulum, which basically runs from posterior inferior to the anterior superior. It's not a straight line. I just put this picture like the trajectory of the cyclone we saw a couple of days ago. It's not absolutely straight, it just takes a curveball sort of a situation. So accordingly, the bone reformation or the bone regeneration inside the acetabulum also tracks similarly. So the areas of the bone where you will have enough adequate thickness to reconstruct or reposition your socket depends upon these aspects. So good bone often you will find posterior inferiorly and on the medial side and a little bit probably on the anterior superior. Of course, today we have various ways we can do a 3D print, we can do a 3D image and study it almost normal, unlike the other times. We don't so much depend upon the radiology. There was a time this was not appropriately understood, and at least it was me, because this was one of my early cases. You would use a bone graft to reconstruct this. But today, having understood, you know the techniques will come. I don't want to step into the rest of the lectures. So they will be describing you how to go about reaming it, understanding these basic concepts of where the bone is and where do you anchor the bone. So where is the bone for anchor? This is how it is. So when you start reaming, you don't take one straight ream like as normally we do, like in the version and inclination, and start going about it. Try to maximize the bone as you expand the socket, having understood and the concept and having understood the pictures, what you see. So start posterior inferiorly, you can gradually, where you have a thick bone, expand it gradually, constantly looking at the columns. That's where you're going to face the fixation. We shall see it during the surgical demonstration also. So where is the bone for the anchor? I think we can sum it up in 2 lines today. Best bone that is loaded. Don't go always for the true acetabulum. Some people, and of course, there is a disputed opinion. There are people who want to go into the true acetabulum all the time. There are others who are appropriately okay with a high hip, which is what, again, you're going to fortunately hear from Amar about his long-term data. Fixation between the columns. You could elevate the hip center. There's not been a problem. And that is the accepted sort of a concept today. A directional reaming, avoid grafts, if at all feasible, all the time. So this is classically seen. If it's a Crowe 4, when there is no articulation, you have no secondary reactive bone, and the best place is the true acetabulum. So this is one situation where it always focus, even though the hip is high, socket is the place to be. You get it, and because you are compelled to shorten, the reduction is not an issue in these cases. So the best bone becomes native when there is no articulation. A few points about the femoral side. I think what is most important for you to look at is the anteversion. The femoral side, oftentimes there may be indicative situations where there is a proximal and a distal femoral intramedullary size mismatch. And this can impact upon the prosthetic choice and selection, or how we are going to overcome. More especially so if you're going to have an osteotomy necessity. So look at the suitability of the standard stem, suitability of the what appropriate stems are ideal. And you can even guide and get this idea even as you progress towards. This will be discussed further in the other lectures. The component fixation, I think, remember, be careful. There are no defining landmarks which are appropriate. The trunk alignment of the guides may be the best way to go. You need to develop an idea. Again, it will be discussed in the subsequent part of the lectures. Option 2 is, if you are very doubtful, put the trial cup, get some fixation temporary, get the fire, then put the trial stem, reduce it to your satisfaction, see if everything is okay, and then commit yourself to the final implant. This is not bad. This you could resort to if you think. But more often, I think with the other things, I just want to stop short saying, socket, be prepared with your very small cup sizes. Very often it will be 38 and 40, or maybe some sort of a bantam cups. On the stem side, have a design that gives you a high versional control, and if at all possible, gives you an independent proximal and distal femoral fit, which will probably obviate all the other situations and obviate the need for any additional fixations. And it should always try to accommodate osteotomy if in case if required. And finally, I think most important, I think going back to the anatomy labs, I think you have to think and understand that all the anatomy will be distorted. Familiarize yourself and anticipate anatomical distortions, alteration in the locations. Where you think the sciatic should be may not be. The femoral posterior, trochanteric is posterior, or probably your position of the greater gluteus maximus insertion may be a little higher. Position of the vasculature will be much closer. And so be attuned and align yourself to the altered orientation of these structures. I think that will save you a lot in this case. Thank you, Anup. And then I will leave it for the rest of the discussion to proceed with the speakers. And I hope any clarification that we can do it at the end.
Fantastic, Suri. That was a great kick-start to this meeting. And I request Dr. R.K. Sharma to share his screen now. And while he's doing that, let me take Vijay into loop. Vijay, so since the morphology is altered on the socket side, would you change the transverse acetabular ligament for your socket orientation? And how would you really orient your socket in terms of version with respect to the tall?
Well, we do not change it routinely. The first thing that I would do when I do a borderline dysplasia 1, 2, or 3, I would look at the femoral version. whether it is very anti-inverted or not. That will be a rough guide for me. And then I would go, if the femoral anteversion isn't too much, then I would respect the TAL and do it on the socket side. And I'd come back and have a stem with a versional freedom. Then I would have a good zone of good combined anteversion. But should the femoral anteversion be very high, and if I think that the socket itself is very antiverted, then I may choose to, this one time when I would put a socket with a trial liner and do my stem, and then think about, if necessary, I'll go back and retrovert my socket a little bit. If I think the combined version is going to be too high.
Yeah, great point. So we have to orient your socket with respect to the femur as well and make your combined inversion so that the hip is stable. Great point there. So Dr. Rajiv, are you ready? Let's go to your case type 1.
Yes. Thank you, Anup. Thank you, Shubhranshu. It was a great start by Dr. Suryanarayan. I'll be discussing one case, which is the post-osteotomy dysplastic hip, as we see here. And we discussed that what are the small issues with these kind of dysplastic hips, which have been operated in the past, and we'll try to explain each aspect of this case. Now, this patient, who is 22 years old, he presented with the pain in both the hip joints, limping, as we can see in the video. There's a shortening of the left leg to some extent, but a very small amount of shortening. It's a bilateral DDH with bilateral pelvic osteotomy done at the age of 6 years, and also femoral subtrochanteric corrective osteotomy, which has been remodeled to some extent. If we further assess the X-rays, we see that this is the arthritic joint. There is a shortening of the left side. We can see that the trochanteric osteotomy, this will cause the femoral impingement. We see that the pelvis is slightly tilted. We see that on the lateral X-ray, we see on the left side more how a osteotomy has been remodeled very well. But there is a deformity of the proximal femur, and how we have to look after this proximal femoral part. The trochanteric impingement is one aspect which should be looked after well. There is a decreased offset on both sides. And if we see the full-length X-ray of these patients, then we should always do the full-length X-ray, because you need to see that what has happened after the pelvic osteotomy or the subtrochanteric osteotomy, how much the remodeling has done. And as we see, the arrow is showing here that the remodeling is reasonably done well, and then the femur looks reasonably straight now. And to some extent, the shortening of the left femur has been compensated as the growth advanced with time in this patient. How we have to plan the cup positioning, the femoral implant positioning. The best ways are the medialization of the cup and restoring the offset. And one must assess before surgery the proximal femur, and especially the canal diameter of the proximal femur, because there may be a mismatch between the trochanteric diameter and the canal diameter. And that's how, if in a patient where there is a problem, the canal diameter is too small, you have to be ready with a right kind of the implant. Like we see in this patient, this is the post-operative X-ray of the patient. We see that the limb length equalization is good. The offset has been restored, and especially the impingement that from the osteotomy point one can have in abduction is reasonably sorted out. We see that even if the cup is 20% uncovered, it is acceptable, but it has to be fixed very well. As Dr. Suryanarayan said very well, that the reaming has to be done in the bone, which is a strong bone. And that's what we see here. In the femoral stem placement, we see that the osteotomy, the deformity is slight, but this implant is able to hold the femur very well. We see this patient at 6 weeks, bilateral total hip, and this patient at 3 years. The fixation is good. There is no issue of the abduction. The patient is able to do the abduction reasonably well, and the patient is able to squat and sit on the floor. Thank you, Anup.
Yeah, so thank you, Dr. Rajiv. And Meanwhile, Dr. Amar can share his screen and we can have some discussion on this case. And let me take Dr. Surya Narayan first and ask him, Suri, what's the importance of getting full-length X-rays? Do they impart some other information to us apart from the length? And when would you do a CT scan for a dysplasia patient? It's two things.
I think full-length X-ray is the wise thing to do all the time, and for two reasons. One, the femoral anatomy. Or we look only at the coronal pictures to get a sagittal image of the femur and whether we anticipate any trouble. That is very important. I think that is one information which you will get. So full-length X-ray, besides the length, I would even look at the femoral anatomy, how well it comes in. And the second CT scan, I think today it's sort of become a normal, I would say, because it doesn't take much. There is not much debate about whether to do or not to do. But is it a requirement? Is it a must? It is not a must. I think that could be debated. In a sense, you definitely get some more information about the situation. If it is a grade 1, type 1, type 2, probably I wouldn't bother much about having a CT scan unless there's any past history of any correction or a procedure which has been attempted in that. But for other grades, probably I would prefer a CT scan. The thing we get, the information we get with the CT is one, the thickness of the columns, where do we have the bone, and how, and where we can template it appropriately, and then probably we can position it, whether we are able to bring it to the true center or whether we will need to probably position the socket slightly proximal within the permissible limits.
Yeah, great. One more point, Vijay, and let me take you in here, is about the choice of a stem. Dr. Rajiv on the femoral side chose a normal stem, fully coated, at least on the left side where there was some femoral deformity. So what would be your choice of a stem in such a case?
My choice would certainly be an S-ROM type stem in this one. And I dare say, Rajiv, well, very good job, excellent result. But the problem with using a standard taper like a Crowe on this one is that you'll get distal fit because of the deformity, and you tend to be undersized. I dare say that your stems are a little undersized. That's because you've got distal fit, and we know now that's one of the modes of failure that we get in the medium term. That when you get distal fit and you're not adequately sized the proximal metaphysis, you may end up a medium time failure. So whenever you've got an osteotomy, I would go for a S-ROM type stem, and this is a little risky. I mean, they've done a great job, but it's a little risky, I would think, yeah.
Because there is a metadiaphyseal mismatch, so it's better to choose a S-ROM type of a stem. So those are two points that we wanted to get home. All right, so let's now invite Amar for his long-term results on type 2 and type 3, and we have all read this paper in core. Amar, please.
Sure, thanks. It's great to see you all. And I'm going to echo many of the things that Suri said. I apologize, I can't share my screen, so they're going to advance it for me. So you can advance the slide. I have no disclosures for this talk, but I think as Dr. Suri said, the literature favors anatomic position of the socket in dysplastic hips. And I'm going to make an argument as to why that was initially done and why now many people have different thoughts on that situation. Next slide, please. So the surgical challenges, we all know that there's deficient acetabular bone stock, and it's usually anterolateral. It's usually a small and shallow socket, as was mentioned. And then there's also increased anaversion in both the socket and the femoral neck. And so all these things need to be accounted for. Next slide. So historically, this was done with cemented cups and cemented stems, and the anatomical position was the most appropriate at that time. Next slide. So the reasons for that is that it recreated a normal joint reaction force, but it didn't always allow for full acetabular coverage. You had very small and thin cemented cups with regular polyethylene. And the quality of the bone in a native socket wasn't always the best. So there were some failures with even going in the anatomical position. Next slide. So they tried the high hip center with the cemented cups, as you can see here. Next slide. But that also didn't work out. That worked out worse than the anatomic center. High rates of loosening and revisions at mid-term follow-up. So this was generally abandoned when using cemented cups. Next slide. The other option of improving the acetabular bone by using bone grafts was popular for some time, but it was technically demanding, and there still was a very high rate of failure and resorption. I think, in fact, the one slide that Dr. Suri showed, you could see the resorption of the bone graft that was there. So that was a very common finding as well. So we were looking for different ways to get acetabular fixation, and we started moving towards more non-cemented fixation in the acetabulum around the same time. Next slide. So one concept that was introduced by Larry Dorr and others was the concept of medialization. It would give you the best bone coverage, and it would allow for better biomechanics. Next slide. So this has some reasonably good data and information, and most people now will try to achieve some level of medialization when you are trying to accomplish your reconstruction. So the one thing you don't want to do is go high and lateral. That can get you into trouble. But if you can go slightly higher, or I would call modified high, and medial, you can get away with it with good fixation. Next slide. So this got us to this concept of, can we do the high hip center again with non-cemented cups and screws, get the best bone stock, get the best bone coverage with medialization, eliminate the need for bone graft, and then use, as we talked about before, modular femoral components to address anaversion and also shortening osteotomies. Next. So here's an example of a Crowe 3 preoperatively that we did a non-cemented cup fixed with screws and a SROM stem that you can see has a derotation in its two components. Now, I would make the argument that even in this slide, we could have probably gone slightly more medial. But in any event, it lasted 11 years, and with the amount of wear it has, it's going to last a lot more. Next slide. So we wanted to investigate the results of this high hip center. And so we did a study that as I said, was published in Core. You can go on to the next slide. We thought there would be no difference. So that was our hypothesis. Next. And we basically did a retrospective case control study. And we had, next slide. We wanted to define the difference between the high hip center and the regular patients, the control patients, by having at least 1 centimeter of proximal migration of the femoral head. Next slide. So this is a roundabout method. You all saw this before. You have the trans-teardrop line, a line perpendicular to the ischium, and that red triangle needs to be in the 2/5 of the total vertical height of the acetabulum. That's the anatomic position. So if the regular cup is 1 centimeter above that, that would be considered a high hip center. Next. So we had 32 patients with a high hip center and 21 controls, and a minimum 10-year clinical and radiographic follow-up. Next. So clinical evaluation was done, radiographic evaluation was done. Next, you can go through these relatively quickly. These are all the radiographic evaluations that we did. Next. This was the Roman method we used to look for wear. Next. And the bottom line is, it was a mean follow-up of 12 years, ranged 10 to 17. We had 23 patients available for review. There were 3 loss to follow-up, no failures for acetabular loosening. I think that's the key take-home message. There was 1 revision for late dislocation. Next. And knee society, hip society scores and Womack's improved dramatically. Next. And as you can see here, radiographically speaking, if you look at the high hip centers to the controls, in the vertical distance, they were at least 1 centimeter above the controls. In the horizontal distance, they were about the same, meaning they both were medialized equally. Next. The wear rates were statistically similar, so that was also very encouraging. Again, this is now using using highly cross-linked polyethylene. Next. So this was the first time we were able to show that you could do a high hip center and have long-term success without using bone graft, using non-cemented fixation. Next. So it gives you good quality bone, as to Dr. Suri's saying. So you want good quality bone, attention to medialization, and you can get away with no loosening, no osteolysis, and again, paying attention to the femoral component as well is important. Next. So basically, you heard about the Crowe classification. Initially, everything was recommending placement of the anatomical position. Next. Now we have a new recommendation, which is basically anatomic hip center for Crowe's 1 and 4. So if it's completely out, but consideration for a high hip center if it's Crowe 2 and Crowe 3. So that's, again, somewhat debatable, but I think for the most part, I feel confident now in doing this based on this data. Next. So I'll just show you a couple quick examples. Here's a Crowe 3, and you can see 13-year follow-up with very nice high hip center and good medialization. Next. But here's your typical Crowe 4, and in this case, I think the answer is next. You can go through the slides. Staged anatomic position sockets. Next. Next. And you can see the final result. So that's the answer for Crowe 4s. No one's going to argue that. But I think in Crowe 2 and Crowe 3, you have some options now with the newer materials that we have. Next. So I think that, I recommend this approach. I've been doing it now still. And even with the advent of acetabular wedges, I still tend to go higher with mildly to moderately dysplastic hips. Next, I think that's it. Thank you very much.
Yeah, great talk, Amar. And as Dr. Suri will load his talk, let me ask you a couple of quick questions. That most of these patients that are reported in the core paper were operated in late 90s and early 2000. And the paper was, I think, published somewhere in 2012 or 13. So in the last decade, has your strategy changed with the advent of newer materials and more studies on the long-term results? Because you reported 1 centimeter superior and medial center of rotation. So has your strategy changed in the last decade?
No, I think if anything, it's maintained. There probably were some patients in there that had direct compression molded poly, but there were more that had highly cross-linked in the latter part. So I think as we got more confidence with highly cross-linked polyethylene, as we've gotten better, even non-cemented fixation. I mean, now with the trabecular metal cups, even the 20% a point that was made of uncoverage, I will push that, much further. We do have augments now, and sometimes augments will allow you to bring it a little bit further down. So sometimes based on where the bone is, and ultimately, it comes down to what Dr. Suri said. It's where the good bone is what makes you decide what you're going to do ultimately. But I still would say more often than not, I'm using just a hemispherical cup, small size, as was mentioned, a couple of screws, and just put it where the good bone is. And I have confidence that the polys these days can handle it. So I'm not seeing wear, and I'm not seeing fixation failure.
Right. So superior and medial is the key to decrease poly wear, and not superior and lateral. I think that's the take home from
Yes.
From your. Let me take some of our other panelists into loop on this one. And Krishna, what is your upper limit for superior and medial cup in type 2 and 3? What's your upper limit? How far would you go?
Maybe up to 2 centimeters.
2 centimeters.
Yeah,
okay,
but it actually is dependent on where the good bone is. So if you have loading there and you're able to get a good socket with full coverage, so I have gone up to 2.5 centimeters as well.
Great. Dr. Mohanty, you want to say something?
Yeah, there's a question from the YouTube.
Yes.
That from Dr. Shuman Maratha. Is the cup always uncemented in high hip center? And second thing, is there any role of cemented cup now?
Amar, can you take that, please?
Sure. I mean, I think there's no role for cemented cups in my practice anymore. I mean, occasionally I'll cement the liner into a well-fixed shell. But so if you're going to go high, the answer is do not use cement. You can get a reasonable result cementing in an anatomic position. So I'm not going to totally dispense with it. But if you're going to go high, I think you need to use non-cemented fixation. That's the key that we were making, non-cemented fixation with supplemental screw fixation.
Great.
Is
Vijay, do
there-
you have anything to add there? Vijay, anything to add in type 2 and 3?
Yeah, I mean, maybe 2.5 is pushing it too much. Now remember, it's not an all or none law. If you
Right.
think that it's a little too high for you, uncomfortable, you can bring it down, a centimeter, 5 millimeter, and then you can use a little bigger cup and still get contact. So it's not like you have to put it high or put anatomical. If you're a little uncomfortable with 2.5 centimeters, you bring it down to 1.52. That's
Right.
also possible.
Take the middle
think-
path. Yes, Amar.
I think the key is, where the head was articulating with the acetabulum is where the good bone is going to be. But you don't need to put the socket at that level. You can drop it down and just use that hard sclerotic bone as your dome.
Right.
So if the hard part, like look at the X-ray that we have on the screen now, I would use that hard sclerotic bone and bring the socket halfway in between the native socket and where that socket's articulating now. So you use that hard bone just for the roof.
Correct. Great point. Great point. All right. So let's now go to type 4s now. And Dr. Suri, if you can show us type 4 case with the STSO video.
Yeah. So I think this is a video, as you said. I'll just, as you requested, 10 minutes, 20 seconds. It's a type 4 Crowe. The middle. Always, I think, make it a habit to take spine X-rays. I think that gives you a lot of information. Very, very important. One point.
Some markings and then start talking.
This is anterior spine. The trochanter, often a little posterior, which has been defined. Be comfortable with the length of the incision. You don't have scrunch. You may not make the full length at the same time. Start, and for the secondary osteotomies, you can do it later and expand it as required. Like I said, I think you must always be prepared for the change of direction of the glute. See, like I'm showing here, very typical, especially with the type 4s. So don't run around. All your adductor, the vessels on the medial side are going to be more proximal than what you normally get. So the rest of the dissection plane is similar. You have identified the upper lower borders of the gluteus. Almost always the gluteus maximus needs to be relieved. So this is a standard step, not an exception and not a choice. It's best is to release the gluteus maximus. I do a complete flap release of the capsule with the posterior rotators as a single complex, a standard procedure. As you take out, there may be some adhesions over the femoral head, and you just need to mobilize this completely. So just work on the bone, on the femoral head, and the moment you take out, now if you see the head comes into vision, the anteriorly you may not. You may probably dissect a little more distal on the medial side of the neck. Like Dr. Vijay mentioned, this is the time we look at the neck anteversion so that you get a rough idea what is the degree of anteversion of the head. And accordingly, you can have that at the back of your mind. If you're using the X-rom, cut it a little more proximal. Don't cut it exactly at the spot. Use the template, but keep some head. That one helps you subsequently to adjust it the way you want it, rather than committing yourself right at the beginning. This is an important aspect. Grab the posterior capsule and pull it up. There's always a ridge of the thick inferior capsule. So to identify the true acetabulum, what you see is just a pseudo socket. You need to pull it down, and once you go down beyond the thickness of the hypertrophied labrum, you will find that inside. What you're seeing in the 4 picture was the pseudo acetabulum. The true acetabulum is right towards at the depth at this point here. You can put your ischial pins. Once you have the true acetabulum, you know the ischium, where it is, the location. So that at least takes some tissues away, and be careful of the size. Again, the bones are a little small. We have now put this on the anterior superior column bone. Give sort of a release over the hypertrophied labrum that gives you some working space. I personally don't put a big retractor. Usually I use a hook to get the femur anterior. That is the thickened labrum. You have the freedom to thin it up a bit. Once you pull this, you're in the true acetabular area. So by just grabbing the capsule, that leads you down to the true socket. And now you have to take thinning out the labrum. As you before you take out all the tissues, you will find the foveal fat. You will find the fat in the fossa. Once you take out, that gives you enough room. And this is now acetabular preparation like we normally do. Having understood, then you guide your position of the cup. You start gently reaming. Be very always. I personally keep trying to palpate the columns in the front and the back so that you're not very eccentric when you're reaming this. And you hardly ever end up going beyond a 38 or a 40 in most of these situations. So just go a little slow. Make sure that you have a good bony contact inferiorly, superiorly. Do not worry about the uncovered superior part. Like for example, I just get the cup in, and then you could just use some sort of a little device and a hand tap finally to align into the position which you think is appropriate. This way you're just able to rotate it, sort of dial it into the position, desired position. The dial position for anteversion and the inclination would be probably the long axis of the body, which you can mark beforehand. But ensure that you have positioned the patient yourself in the dead neutral position. The cup is then sort of impacted inside. You will have a fair amount of uncovering on the superior side, even though you may have medialized completely, but that's not an issue. The gap here is between the anterior and the posterior columns. Never leave yourself to the temptation of not using a screw. It probably is much more safer and wiser to use one screw at least. You can fit in your socket, so that sort of completes the socket story. And then you can recheck regarding the position of the socket, the way you normally pass. Now what I'm doing here is, if you see the proximal part, I'm trying to give it sort of a preliminary traction to see how much is the reducibility, especially if the stem has been a mobile type 4. Having done that and having committed to using a sleeve-in stem design like a SROM, I prepare the shaft. The last one reamer, I personally probably prefer to do it with the hand, just with the feel. The reason that you get the true natural feel. You could well do with the machine if it is very sclerotic, but if you can do away with the hand, probably that may be a better option. The sleeve is prepared in the conventional manner. Again, choose the axis of the maximal bone on the neck. Sometimes if there's excessive anteversion, you may have to get the sleeve in that axis. You don't have to get it into the normal anatomic anteversion, wherever the bone carries you into the sleeve. The preliminary sleeve is then impacted. You must know the length of the sleeve and how far distal you have gone, and what is your landmark proximally to measure the depth, so that you have a visual idea on the outer surface of the shaft to know how far the reamer, the sleeve has gone in. I've now tried to putting the trial stem inside. Now we get an idea of the anteversion again. This is a long limb and the knee axis. Both of them guide you to get the adequate anteversion. But then we have still another point, especially since you are doing an osteotomy, to fine tune this and adjust the version even at the level of the osteotomy. You could well do that. This is the preliminary marking on the shaft so that you don't veer extreme rotations in the rotational mismatch between the proximal and the distal segments. Having done this and having marked the distance of the sleeve from the top to the point, now I know that the prime proximal cut will be at that point. So we do the proximal femoral osteotomy at this level. And then you dissociate the two segments and separate it out completely. Let them be free of each other. Come back to the femoral side, reinsert the stem. Now, having separated out the segments, you would find that it is extremely easy to dislocate reduce the head. Remember one thing, the tissues, if they have not been operated, do not undergo any change in terms of their tissue tensions. And you can just, with the flick of your hand, you can reduce the head. Having done this, you oppose the proximal and the distal shaft one next to the other, like you see on the picture. Based upon this, you can mark the first line, which will be the amount of bone that will be resectable, and then give a very heavy traction, which will take you further down by about 5 to 6 millimeters or 7 millimeters, mark another point. So these are your two optional levels of bone section that probably would be required and desirable. Preferably do the lesser one, see the reduction. If it doesn't reduce and you have intense resistance, both towards the sciatic nerve palpation or in the practical reduction, you can always come back and remove more. Then I do the little bit of the medial release, take off that whole segment or the dowel of the femur, and then you can realign the shaft, both proximal and distal, get your distal shaft inside, the stem inside. There are two problems you might notice sometimes is a distal mismatch in which there may be a rotational instability. Do not worry about it at this time. But if you could probably upsize it if possible, the sleeve one more and then go up, it may be easier to reduce the hip. Now with the whole construct in place, try to reduce it. If it reduces well, I think it is pretty much comfortable. Then you can proceed with the final fixation. This is the final sleeve being fixed. The problem of a mismatch and a rotational instability will need to be addressed. Some prefer to see if you can get a one slice sleeve more. You can re-prepare the distal shaft to one higher shaft of the stem size, and then you can go ahead. In next round, we have a differential. We are committed. One sleeve will only take that diameter of the stem. So that is an issue. So work on this, see as much as you can, but at no point be over adventurous, because if you shatter the proximal segment, I think it calls in for a lot of trouble. See, the final reduction again is west with the thumb, not with any big contraption. You are able to reduce it completely inside. And there you get the picture. Then you do the routine test for your stability. This was the post-operative picture. Like if you see, there was a couple of millimeters left distal to the sleeve, which is uncovered so that you are safe from that point of view and the reduction is achieved. Thanks, Anup.
Yeah, great, Suri. Great video and some great points. Let me initiate the discussion. Let me initiate the discussion by asking you two things.
Can't hear you.
Yeah, just Rajiv, just a minute, please. Yeah, Dr. Rajiv, I'll come to you. Just a minute. Yeah. Dr. Suri, let me initiate the discussion by asking you two things. Would you do the SO as a part of the exposure? That is, do it at the outset so that your acetabulum exposure becomes easy, number one. Number two, what's the point of your osteotomy below the sleeve? How many millimeter or centimeter below the sleeve is your osteotomy? Suri, can you hear us?
I don't think that he's able to hear.
Suri?
I can answer that.
Yeah, yes, please, Amar, yes.
So I think, in a Crowe 4, where I know I'm going to do a shortening osteotomy, I usually do it right away. So I prepare my femur first, prepare the SROM, because that's pretty easy. Then I will do the osteotomy, expose my acetabulum. It just makes, as you said, all the exposures that much easier. In a Crowe, say 3, where I'm not, and I'm going to put a little higher hip center, I'm not sure I'm going to need the osteotomy, then I do that afterwards as I would make an assessment.
Great. And how far below the sleeve is your osteotomy?
I like to make it about anywhere from 1 centimeter to 2 centimeters below the lesser troch.
Great. Dr. Mohanty, is there a question from the audience?
Yeah, from YouTube. The first question by Dr. Somashekar is that is it mandatory to isolate sciatic nerve in all cases of DDH?
Dr. Suri, are you with us? Suri, are you with us? Suri, Vijay, can you take that question? Is it mandatory to isolate the sciatic nerve?
It's certainly for a Crowe 1, 2, 3 is not necessary at all. Whereas for a Crowe 4, I would think it is very much necessary, at least in my hands, because that will tell me how much of lengthening it will handle. So if I find that the sciatic nerve is getting too tight, I'll take more segment and sort of decompress the hip. So for a Crowe 4, always sciatic nerve tension is very important for me. For 1, 2, 3, not required.
Just 5 minutes.
Yes. Amar, you want to say something? Yeah.
Yeah, I mean, I think you identify it in the sense that you feel where it is. You don't mobilize it or expose it. But I disagree in the sense that for me, the answer is reducing the hip. Once you can reduce the hip, I'm not worried about the nerve. If you can't reduce the hip and you force it in, that's when the nerve gets into trouble. But if if you've done, how Suri showed that the reduction was sort of a reasonable one, the nerve is going to be fine. I mean, but you should feel it and be aware of it. So I think those are, our take-home messages. It's the reduction that determines how much bone you need to take and how much stress is going to be on the nerve.
Great point. Yes, Dr. Mohanty.
The second question from Dr. Manoj Wadhwa. Awesome surgery, dear Dr. Suri. Any role of working on acetabulum through the STSO fragments area of the femur?
Yeah, I think we discussed that, but maybe Dr. Suri can also answer his point of view. Suri, are you with us?
Yeah, yeah, I am. Can you hear me?
Yeah, so do you do the STO at the outset to expose the socket and prepare it?
That will be probably an option. I have never used it, but probably if it's a very tight hip, for some reason, probably there's an excessive scarring and the hip is very high, then probably it may be you can do the primary osteotomy and then go ahead and do the socket. Yes, the socket exposure probably intuitively would be much better, but if you're not familiar, probably it may be feeling a little messy. So I don't usually adopt that technique. You are able to, with the appropriate releases, you are able to get it adequately good, even with this standard exposure. Yes, it is.
Yes, Dr. Bende. Yeah, yes, please.
There is one point which Amar mentioned. I wanted to repeat that if you are going to use the subtrochanteric osteotomy as an approach to expose the acetabulum, you must prepare your femur first. You cannot do the osteotomy, get the exposure, put an acetabulum, and now you have got a proximal free femur which you are trying to remapping. So that is very important point which he mentioned.
Yeah.
I just want to re-heighten that because otherwise it could be in a big trouble. We could be in a big trouble.
Correct. Great. Yeah, that the point needed re-emphasis. Yes, Dr. Rajiv, you wanted to say something.
I was mentioning the same thing as you asked, the timing of the subtrochanteric osteotomy. And where you are very sure that you need a subtrochanteric osteotomy, then it's a good idea, as we have discussed just now.
Yeah, so we discussed
do the subtrochanteric osteotomy, use it for the better exposure. And as Harish and Dr. Surenarayan rightly say, that they prepare the femur first before you do the subtrochanteric.
Yeah, of course. Yes, Dr. Mohanty, any more questions on that? Yeah.
Yeah, the question for Amar that is there proposed difference in the size of the cup used between anatomical and high hip center cases?
They're going to both be small. That's the bottom line. And I think those are the decisions that you have to make. If there's adequate bone stock in the anatomical center, then it's fine to go there. But the problem is there usually isn't adequate bone stock, and more importantly, the bone is generally not of good quality. But the size issues, they're both going to be generally on the smaller size.
And one more question is that when do we do the adductor tenotomy? Is it before surgery or during after the surgery in a high hip center?
Yeah, I think you pretty much want to release everything around the proximal femur except for the abductors if you're doing a Crowe 4, if you're trying to bring it all the way down. So, I generally do it as part of the, I just sort of spin the entire proximal femur all the way around, release posterior, anterior capsule completely. And then at the very end, if I'm still having adductor tightness, you can always do a percutaneous release. But I don't do it in the beginning.
Yeah, so Suri, in India, generally we get just 122 millimeter head. And because we're working with 36, 38 cups, you need a 22 head. And with SROM, they just give you one head. So any tips for your osteotomy? Will you make your osteotomy a conservative one and then increase if required, or any tips on that?
That's what I was coming, because more often than not, your stem offset also will be 30. There's small made femurs, unless you're lucky enough to get a 36 offset, especially with the SROMs. With this, the 22 head undercut the neck initially, and then you can gradually take more if you want later point, because you have no option, and you will get only a 22 metal head and no more, no less. So
that's right.
You have to play with that. So always a good idea to cut less, keep the bone, and then go as it goes, see the difficulty of reduction or the restoration of the lateral balances, and accordingly then you can work. Because once we commit ourselves to a good cut and a 36, and if it doesn't reduce, we are in trouble. So keep in mind that there may be a requirement to adjust with regard to the lateral offset of the stem which we use and the size of the stem which we use. So
Great points, those. Vijay, you wanted to add something, Vijay, on that?
Yeah, the one is the neck cut. You can also compensate for the neck cut by in the subtrochanteric region. You can compensate the rotation, you can compensate length, everything can be compensated in the subtrochanteric region. So that gives you more leeway to work.
Yeah, Krishna, can you start sharing your screen, and maybe I can take one question to Raj Kumar. He's unusually silent today. Yeah, so.
No, Anup, you are the master here.
No, but yeah, okay. So as Krishna is sharing his screen, Raj Kumar, so most of these cases, type 2 and 3 are valgoid. What about dysplastic varus hip? So these are all kind of valgus, all the cases that we've seen. What are your points on a varus kind of a dysplasia?
Yeah, the varus kind of cases, obviously we don't need to do a subtrochanteric osteotomy. And almost always we can get the cup into the anatomical position. But the more importance should be given to the stem side and offset. So we have to select an stem which we can sink very much into the femur, and offset which allows us to sink the implant, the stem, particularly in a stem like SROM, where we can sink as much as possible. Definitely a stem like a corail, which has got a very high offset, is not an option at all. So varus deformity, you have to be very, very careful. You can take a very low cut, neck cut, very low, unlike in a valgus hip. Here you take a very low cut, sink the stem, and try to put the cup into the anatomical position.
Great. So those are the points on the varus kind of dysplasia. All right, so we'll continue to discuss type 4, and let's now go to Krishna for his presentation on type 4. Krishna, please.
Thanks, Anup. I'll be switching off my video because the video doesn't play as well. So this is a hip dysplasia case presentation, and we've had very eminent faculty already look at the various aspects of hip dysplasia. So what I have looked at it and found in my practice are there are variations in the Crowe 4 as well. So you could have a normal looking supratrochanteric anatomy like that. You could have an excessively overgrown valgus with a hypertrophied neck type of pattern. You could have a varus pattern with a trochanteric overgrowth, which is a combined supra and infratrochanteric shortening. Or you could have operated cases where there is some sort of a subtrochanteric procedure which has been done like a Shan's osteotomy. So these are all the 4 variations which I have encountered in my own practice. And the management of each is different. However, the key principle in a Crowe 4 remains this: the hip center is anatomic, and we must calculate the difference between the femoral center of rotation and the acetabular center of rotation. And if the discrepancy is 3 centimeters or more, then we are looking definitely at a subtrochanteric shortening, whether it's a 3 or 4 type of dysplasia. So it's a surrogate marker. And by and large, we will be doing some sort of a subtrochanteric shortening osteotomy in these cases to offload the sciatic nerve. So this is the case which I'm going to present. So Dr. Harish was talking about how we must prepare the femur first. And sometimes it may not be actually possible to prepare the femur first because of this sort of an angular deformity in the proximal femur. In this 49-year-old man who had a hip operation done 20 years back, some sort of a pelvic support osteotomy was done. And now he's come with severe pain. And unlike the classical dysplasia, this hip was stiff and this patient had restriction of activities of daily living. And he also had a femoral osteotomy done distally down to varize the femur. And as you can see, the length of the femur is longer than the other side. So it is one problem less where we can actually restore the leg length after surgery. So there's no shortening because there was some femoral lengthening procedure done distally. So the plan for this particular case was that we would do an anatomic hip center, and we anticipated that we would have to do a shortening at the osteotomy at the level of angulation. Now, typically with SROM, we tend to put a sleeve in, prepare the femur by distally sizing, putting the sleeve in, and do an osteotomy about 1.5 to 2 centimeter distal to the sleeve. But this particular case, we had to do an osteotomy at the angulation and then shorten it upwards, unlike what we normally do. So that was the plan, do the osteotomy first, and that will help the acetabular exposure. So that was what was done. Then the acetabular preparation was done. Then we held the proximal femur with bone holding forceps, and then did the sleeve preparation and shortened a segment from the proximal as well as distal parts, and then went with the surgery. For a standard SROM for STSO, however, the key principles are like this. You have to size the distal canal. You prepare the sleeve corresponding to the distal diameter. You osteotomize the femur 1.5 to 2 centimeter distal to the sleeve after marking the component the femoral rotation. And you can use a similar size sleeve on the outside to make your mark. You do a circumferential femoral release except abductors to mobilize the proximal fragment. The acetabular exposure and preparation becomes much more easier. The modular stem is placed into the sleeve and comes out of the osteotomized proximal fragment, and the hip is reduced. The extent of overlap between the proximal and distal fragments is measured at rest and with traction, and usually the shortening is somewhere between the traction and at rest overlap. The shortening is done conservatively and increased as required. And at this stage, I must emphasize that the distal canal must be resized, and additional sleeve preparation is done as deemed necessary, because we are going to remove a part of the isthmus, which probably is the narrowest part of the femur, and the size can sometimes vary between 1 or 2 sizes up, and then you have a problem with fixation of the subtrochanteric osteotomy if you don't account for that. The real implants are inserted and the hip is reduced. So this is the video of the case in picture. So we had to expose the thing, make our measurements of the length and offset of the on the femoral side, and then we use the template to make the neck resection. One important tip for SROM is, as Dr. Suri pointed out, the cut is conservative and it is more horizontal. So you have to seat the spout inside the bone. So you make a horizontal neck cut. You don't make a angular neck cut like for Crowe, for example. The head was removed in this particular case, and then we proceeded to do the osteotomy at the level of angulation. And once this was done and the femur mobilized, we were now able to expose the acetabulum and prepare the acetabulum at the anatomic acetabular level. So typically in a Crowe 4 dysplasia, the best bone is at the anatomic level, and we have seen from literature that higher hip center in these particular cases are prone to greater failure. So the real cup was inserted, and usually the cup is less than 44, between 36 and 44. So you must have the bantam cups available, and always use screws for fixation, because these bantam cups can pull out if you don't fix the thing with screws. It's always a good idea to fix with screws. You can use a trial liner or a real liner as we used in this particular case. Then the proximal fragment was held, and we sized the proximal fragment because the isthmus was attached to the place where we did the osteotomy on the angulation in the femur. And then the proximal sleeve preparation was done as would normally be done. And the distal diameter will determine the size. Typically, there is a discrepancy between the stem size and the sleeve size. So you have particular size sleeve for the particular size stem, and you have different anteroposterior and mediolateral combinations available. The sleeves are labeled as B, D, and F, and then you have small, large, and XXL on the mediolateral side. So once the conical rimming is done, the sleeve preparation is done as per the best available bone in the proximal femur. The sleeve is inserted into this particular segment of bone. So you have markings on this particular device, which will tell you the neck length which we have to use. We have 3 options for SROM: 30, 36, and 42. And these give around 28, 34, and 40 millimeter of horizontal offset if we use a 0 mm head size. So the tip of the trochanter and that line must be marked, and usually we use a 30 neck length for the dysplasia cases because there is some level of contraction. So in this case, we had to improvise. We didn't use the stem. We just used the proximal part and reduce the hip into the proximal fragment into the acetabulum. And typically, as Dr. Suri mentioned earlier, it's quite easy to reduce the thing. The only thing is that the proximal fragment is abducted. And when we are measuring the amount of shortening, this must be calculated, because when you bring it back to the neutral position, typically a little bit more amount of bone needs to be removed. So in this, we have seen the extent of overlap, marked it, and both in at rest and as well as in traction. And part of the resection was done at the proximal fragment. And this is how you can mark your sleeve position. A similar sized sleeve is positioned on the outer surface of the femur, and you mark a 1.5 to 2 centimeter part distal to that particular sleeve. And this will give us good compression at the osteotomy. And then we did the shortening osteotomy. Part of the shortening, we measured that around 5 centimeters needed to be shortened to bring this hip back down. And part of the osteotomy was done in the proximal fragment, and part of it was done in the distal fragment to be able to reduce the hip safely. It's always a good idea to palpate the tension of the sciatic nerve, as has been mentioned. And we can use the segment of bone which has been removed as a onlay graft on the osteotomy side and fix with encircler wires for better fixation. So as you can see, we removed around 3.5 centimeters from the proximal fragment and an additional centimeter from the distal segment. And then you resize the distal segment and see if there is any alteration which is required to be done to the size of the sleeve. If required, this must be done. Otherwise, there is no guarantee that it will give us rotational stability at the osteotomy size, which is very, very critical. So we always resize the thing after the osteotomy is done. And if required, re-prepare the proximal sleeve. Typically, you may have to upsize by 1 size or so. Then you can do your trial reduction using the trial implant. And the real implant above 11 millimeters is around 1.5 centimeters larger than the last frame diameter. So if you are putting a 11 millimeter stem, typically the flutes are around 12.5 millimeter. So you can over-ream by 0.5 millimeter to get good fixation distally. So you can ream up to 11 or 11.5 to get a good scratch fit with the flutes distally. So as we know, 2 important steps: distal sizing and good fitting of the sleeve with no interface mobility, good axial stability, and good rotational stability, because that is where the ingrowth will happen. And distally, the flutes will fix and help you stabilize the osteotomy. So the trial is once again done. And then finally, once you're satisfied with the trial reduction, you can go back and put in the real components. And usually, the osteotomy doesn't need any additional fixation. You can get good stability with the SROM device alone. And we always use the resected segment of bone as a sort of an autograft, onlay graft at the osteotomy site and fix it with encircler wire. And you can see that the entire femur is moving after the real implantation. So that's the post-operative X-ray. And one could be critical and say that probably the cup is more inferiorly located, which I acknowledge. There was some inferior location, but there was adequate fixation. And this is a follow-up at a few months, a few weeks later. And that's a patient who is able to ambulate quite well. Thank you.
Great. Krishna, can you go back to the post-op X-ray? Maybe you can discuss a few important points there.
Sure.
Yeah. So Krishna, you rightly mentioned that after STSO, you removed, this was a case of a double deformity, a very rare case where a proximal deformity was compensated by a distal osteotomy. So any which ways, when do your osteotomy, suppose you are 11 distally and you have a 16 sleeve up there, and you do your osteotomy and then you realize you can ream one more up. So you do a 12 reamer, but your proximal canal is still not good enough to take a 17 sleeve or a 1-up sleeve. So what are your tips on that?
So usually, if you're not able to put in because of a proximal distal mismatch, we have seen that happen in some sort of trochanteric overgrowth with a Varus pattern of dysplasia, which I showed you. You can just
Hello, we lost Krishna, I think. Yes, Amar, would you continue from there? Yes, please. Your tips.
So yeah, I would say he mentioned it. First of all, he did a great job. It's a great case. But I think this happens all too often, is putting the cups too low. right? I mean, now you're making your life even that much more difficult. So that needs to be stated again, that you need to pay attention. He's got some good bone, more superior. So I would get that cup a little bit higher for sure. That was mentioned. I agree using the bone graft, that's fine. I'm a little concerned though that the wire is kind of at the level of the osteotomy. So that's a little bit, concerning. It was mentioned several times that in order to get distal fixation, you want to go up in stem size and therefore you have to go up in sleeve size. And that's true. But there's nothing wrong with putting on if you can't do that, putting on a hook plate and having a couple screws and cables proximally and distally just to hold the osteotomy until it heals. So that's another alternative. The final thing that happens that I've seen is that it's the opposite problem. As you put the real stem in, it distracts the osteotomy. And you actually need to over-ream the proximal part of the distal fragment just to get the stem to go down, and you get engaged at the tip of the stem, but not at this level, if you can see my screen. But yeah, so all those three scenarios can happen.
Right, great. So Vijay, can you share your case now, Vijay?
There are some questions.
Yes, please, Dr. Mohanty, yes.
Yeah, there are some questions in the YouTube that anybody uses a dual mobility hip in dysplastic hip. That is from Dr. Ramnik Mahajan.
Anybody uses a dual mobility?
Usually no.
Vijay, Suri, would you ever do that? Use a dual mobility in dysplasia? Any special situations?
In a Crowe 4, typically you find that that the reduction is very tight by definition, because your shortening osteotomy is now defining the tension of the hip. So it's very stable. So no need to use that. In in other cases we don't, like any other hip. When you use a high hip center like any other hip, so we don't find any indication specific in dysplasia to use.
And the cups are usually smaller size, as Amar told that we don't use dual mobility. And
that's true for Crowe 4, but Crowe 2, 3 we typically use a size. Nowadays dual mobility starts with 42.
Yeah.
So size is not the issue, but not required.
And next question is that by Dr. Manuj Wadhwa, for Crowe 4 supra-trochanteric shortening, any change of plan?
Supra-trochanteric shortening.
Yeah, I don't understand.
Krishna, Krishna, can you take that? But I didn't understand what is supra-trochanteric shortening.
Yeah. So it's like
above
this.
The lesser trochanteric, maybe. Yeah.
Crowe 4, you will always have subtrochanteric shortening, but you will also sometimes have a combined supra-trochanteric shortening. By that you mean the center of the tip of the trochanter to the center of the femoral head. So if the femoral head is below the level of the tip of the trochanter, that is supra-trochanteric shortening. It happens usually with more of septic arthritis type of situations where the femoral head is destroyed. You have the center of the femoral head below the level of the tip. But some Crowe 4, you can have a combined variety where you have subtrochanteric shortening, it's gone up, but also you have a trochanteric overgrowth like a picture where the center of the femoral head is below the level of the tip of the trochanter.
Yeah.
And so one more question. Yeah, one more question is that any role of chevron osteotomy for stabilization and rotational control?
So always a transverse osteotomy, there are many variations. Krishna, what do you do usually?
So I do a transverse osteotomy most of the time.
Most of the times it's transverse. Yes.
Yeah.
You have step cut, chevron, and oblique osteotomies, which are
that's right.
And any tips to stabilize the osteotomy fragments while you are inserting the stem during surgery?
Yeah, that's a
you can
great
use
technical pearl. Yep.
You can use a bone holding. You have a lanes forceps to stabilize the thing, and you can match the rotation because you have marked it before the osteotomy has been done. But still you can adjust the thing. The rotational position is important to position your abductor in the correct position. You don't want to change the direction of force of the abductor. So it's important to get a good rotational position on the femoral side. You mark a long segment, and you can make drill holes as well, and then hold it with a bone holder, and then insert your real implant.
Yeah. Anybody uses plate and screws?
Yeah, I think Amar
That-
mentioned that
Yeah.
plate and screws can be added if you don't have enough rotational stability with the stem that you sized. Yeah, Krishna, but it's not always necessary to match those marks. Suppose your trochanter is actually posterior, you would like to get it lateral. So you can actually derotate it if it's too far behind, isn't it?
That's absolutely true. Yeah, that's true.
No, the
Yes,
Anup,
Vijay.
the only issue is sometimes there's a contracture, external rotation or internal rotation contracture.
Yes.
And the marking the line will tell you that you got to release that rotation. Otherwise, like
Right.
Krishna said, you'd end up abductor not being in the abductor position. It'll be either very anterior or posterior. And that's the only reason why you want to match. For no
Correct.
other reason.
Correct, of course. Okay, Vijay, let's go ahead with your case.
Right. Okay. Okay, guys. So we talked a lot about the socket. So now we go to choosing the femoral side implant. So this is my case. So she is 35, female, history of childhood problem with the left hip. So she had a history of surgery in the left hip at 5 years of age, details of which are not available. Now presents with complaints of increased pain and limb for the last 2 to 3 years. Needs frequent use of painkillers. Use a stick on the right side for 1 year. She's got a gross limb, stiff joint, shortening of 3.5 centimeters. And what is the other point here? Scar on the anterolateral aspect in the iliac region she has here. So I think the socket is relatively straightforward. We have discussed all that. So what is the choice of implant on the femoral side? So just to, it's a very simple case. So let us get an opinion here. So what would be the choice of implant on the femoral side from the faculty?
Yeah, okay. Amar, choice of femoral implant in this particular case?
I would start with trying to do an SROM. And as he showed in the his first slide, if there wasn't good metaphyseal bone to get the sleeve in, then I would do a more distal fitting stem.
Okay, like a Wagner or?
Yeah, like a Wagner.
All right. Dr. Bende, what would you like to do?
Distal fitting stem, okay? Yeah.
Okay.
I think SROM should be the first choice. And probably if you keep a portion of a head intact, and then you probably can get a sleeve there. But if it is not suitable, that you can come to know once you start preparing it. Only thing is the cavity, femoral cavity has little angulation there. So to be a little careful putting your stem inside. You may end up putting a little smaller stem than what you actually need because of the angulation in the cavity there. But SROM, if it doesn't work, then something like
apart from SROM, any other faculty would say SROM. Yeah.
Yes,
Okay,
Dr. Mohanty. Dr. Mohanty.
I would yeah, there is a choice with SROM, but why not cemented stem? Because the metaphyseal bone doesn't look to be very good. SROM, will be a good choice when you have a good metaphyseal bone stock. Why not a cemented stem?
Okay.
Wagner is obviously choice.
Okay, you have a difference
We'll
of
proceed
opinion
on.
there.
Yeah. Okay. So we got the opinions.
Cemented is option.
So the femoral side issues in dysplasia, the increased anteversion, as you can see in this picture. Then nowadays we have two options. We have the SROM and also the cone Wagner. Both are excellent stems, and we have used a large number of both the stems in various dysplastic situations. Now this increased anteversion is well appreciated, but is not so well appreciated by junior surgeons. Is Coxa, valga, and low offset. Now both these stems address all three issues very well. So although both stems have a neck shaft angle of 135 degrees, they're able to address Coxa, valga very well. This is for the juniors, not for the faculty. So if we take this a standard stem like a Crowe stem, it has got a very limited scope for changing the version. So it's not adequate in dysplasia. So at least you must have some other backup stem. So with the SROM, you have unlimited rotational freedom. You can swing it 180 degrees one way or the other. And same with the cone Wagner as well. We can swing it 180 degrees either way. So that's great. This is everybody knows versional freedom. But it's not so well appreciated is how do we manage the Coxa valga with this? So how we do that is if we use by choosing a stem that has got a freedom of craniocaudal placement. So suppose you have a standard Crowe type taper, you do have a little bit of freedom, but very little. You can make it little up, little down, but very limited in scope. Whereas in contrast, if you have a cone Wagner, you can leave it really high, the shoulder at the level of the great trochanter or even higher than that. and then you can sink it lower, or you can sink it really down as well. So that gives you this craniocaudal freedom. And that's how we manage Coxa valga. Although the stem is 135 degrees as the corail, we are able to manage Coxa valga. The little different mechanism that we use in the SROM, so we can leave it really high by having a bigger sleeve, because we are doing an intraop customization of the sleeve. So we can sink it further with a slightly smaller sleeve, or sink it even further, the small, depending on the dimensions. So we can play around with intraop customization, and thereby we solve the Coxa valga problem. Not well understood by juniors. So both these terms are great. Now, managing low offset is again very important, not well understood. Now, I'd like to make a point that the corail, the 8 corail that we commonly use in our country, has got an offset of 38. That is huge. So if you have a real dysplasia, use a corail, you're really asking for problems. Whereas if you use a SROM, you get a standard offset of 28. That is great. That's a centimeter difference of offset. Can you make out? Centimeter difference of offset. If you use a cone Wagner, it's 26. That's 12 millimeter less than the corail. So great option for low offset. So that's how we tackle all the 3 problems, by choosing the stem appropriately on the femoral side. Now the question really is, when would you choose one over the other? Both are great stems in dysplasia, both work excellently well, both have got long-term results. But the question is, when would you use which one? So the SROM is very obvious. When you get a subtrochanteric osteotomy, it's made to order. You know, the various steps we discussed, both Suri and Kiran showed us excellent examples of how we do it. So it's great to use the SROM. It's just, I mean, it's what the doctor ordered for when you need a subtrochanteric shortening osteotomy. Here is not my case. Somebody else has used a cone Wagner for this one. It's very difficult to do. And, but I wouldn't attempt doing it. I would certainly use SROM when I need a subtrochanteric osteotomy. And my question to the panel is, when is a cone Wagner superior to SROM? When would you choose cone Wagner? Anyone wants to take that on?
Amar, would you take that? Then
Yeah,
would you preferentially use a Wagner?
Amar already answered that. Amar has told his opinion. Anybody else?
When the metaphyseal bone's unsupported. And sometimes it's unsupported because you break it. I've seen sleeves go in and you crack the femur, the metaphyseal bone of the femur. You can try to put a cable around it, but at that point, you're probably better off going distal fixation.
Yeah.
Yes, Krishna.
When you have proximal distal mismatch.
Amar, by distal fixation, what stem are you talking about?
Well, I mean, listen, I think depending on what you're dealing with, like in this case, you need to go longer with this stem. So whether it's monoblock or modular, that doesn't concern me as much now. The results are pretty similar.
Right.
But,
okay. Fair enough. Okay. Anyone else? Harish, anybody you want to add?
Yeah, Vijay.
Not good enough to put the cement space. If you have a proximal femur, which is not good to put the sleeve, then you can have just an axial monoblock implant like a Wagner. Because you need to have a conical bone in the proximal part where you can put the sleeve.
Yeah, that's right. Yeah. So the real thing is, when you have a proximal distal mismatch, now we're not talking about the Dor index. The Dor index is quite different. It's about the cortical thickness. This is the Nobel's flare index. That means if you measure above the lesser trochanter and at the isthmus, roughly it must be 3 times. That's how the metaphysis flares off. If you don't have the flare, then SROM may not be a great option. Now this comes in 2 types. You must, although it's mismatch, you must differentiate the 2 types of mismatch. If A is smaller, it's a good indication for a cone Wagner, which scores over the SROM in this particular situation. Whereas B is large. Typically, when you have an osteoporotic bone, both don't do well. Cone Wagners don't do well. SROM also will find a mismatch because there is osteoporosis of the diaphysis. That's not a good indication for both. Then that's a little different scenario. But if you find that you know flare, then you find that the cone Wagner scores over the SROM in this particular situation. So we go back to our case. Now we want to look at the flare. So on the right side, you can see an excellent flare 3 times, whereas on the left side, you find both are equal. There's no flare. So this, I would think that the SROM is not the best option, and the cone Wagner would score over. It's a very short stem. You don't want to get a distal fitting stem inside. So this day and age, I would probably use a cone Wagner. This case I did in 2017. Not aware of this. So I thought I could manage with SROM in any case of dysplasia. So I chose an SROM, and as Amar predicted, when I tried to stuff in that's exactly what happened. So because no flare, it wouldn't take the sleeve at all. So it cracked. Now these days we have a cone Wagner always in our OR, but those days we didn't. And so I had no other option but to come out with the, just putting a wire for that, and came out. And then 3 days later, we went back in. And this is the trial cone Wagner. And you can see how there's absolutely no flare, absolutely zero flare. Now, any type of distal fitting Wagner in these young patients, I'm not very keen on that. So I'd rather use something that is very small and conservative. So I think a cone Wagner fits the bill, and that's the final thing. And that's the immediate post of X-ray. She's got a bit of pelvic obliquity. And 2008 she corrects it. And 2019 she's more or less corrected, and then she's doing very well. Very happy with the outcome. So thank you.
Great points, Vijay. Those so metaphyseal diaphyseal mismatch, a reverse kind where the metaphyseal is too tight to take the sleeve. And Vijay, would you add an indication of a septic type of a case where you still need a very low offset, lot of fibrosis, and a very low offset post septic? Would you add that as an indication for a Wagner?
Yeah, this is I think this is a case of this is a high rating hip. I don't think the dysplasia, I mean DDH. This is probably a septic hip, though, although we don't know the etiology. So, this Krishna was mentioning about the supra-trochanteric and the infra-trochanteric shortening. Yeah. So that basically, to put it in a nutshell, there are high rating hips. Some are DDH, classical DDH, where all the shortening is subtrochanteric. Something mimics a DDH, but it's not DDH. Usually it's a post-septic scenario where you find a lot of fibrosis around, where the shortening is supra-trochanteric, where you keep on doing releases to get that done. And usually that would suffice. It's rarely that you would need a subtrochanteric shortening to compensate. So two little different scenarios here. Yeah.
Correct. All right. Great points. Those on the socket and the stem. Yes, please.
Can I just add just a point to make here?
Yes.
Is beware of when you use the cone Wagner is a wonderful device where, because every incremental millimeter gives you to go down or keep it a little proud by just upsizing it. But don't get deceived by the numbers. You will sometimes often find that you need numbers, size 18, 19, 20. So if you are using it, make sure they keep it right from 13 to 23 or 24.
And Suri, just extrapolating that point, are all conical monoblock stems the same? We talked of Wagner, but there are a couple of others available in the market. So, are they the same, or should you use them with caution, at least in dysplasia cases?
What are you referring to, Anup? Which stem are you referring to?
Like a monoblock stem from other companies. Maybe Smith Nephew, the Redept type, or maybe one more is available on the market. They are also conical. They also have fins for rotational stability. Can you use them for Wagner, or they're different?
Suri, you had to unmute yourself. Yeah.
I'm not really certain, because the angle of divergence for the cone Wagner, as they have given it at about 5 degrees. Like, the same size of your fitness for the radial fins. You can increase the rigidity of the whole system, but I'm not certain about the other ones. If they have the same profile, I suppose it works. But as of now, I think our experience has been only with this. So it's very difficult to comment how well the other ones work. But if if it is the same, it should work.
Right. Okay, Vijay, anything to add there regarding other monoblock stems?
I'm not sure they're all cylindrical stems, what you're referring to, but the cone Wagner has got both proximal. It's not entirely a distal fitting stem. It's got excellent proximal fit as well, sort of a combined fixation, yeah. But I'm not sure about the other stems.
So it's cone within a cone, yeah, all right. So let's go on to the complications now, and we have 3 more cases for the complications. And let me invite Rajkumar first.
Yeah, can I share my screen?
Rajkumar, can you share your screen, please? Yes, Amar, please. Yes.
Yeah, I just want to make one point, which is...
Dr. Bose has to stop sharing.
Sorry. Just
it's okay.
It's okay.
Yeah, there we go.
Yes, Amar.
I just wanted to make one point that the problem with using the cone Wagner and using the SRAM is they're 2 different companies. And I would much prefer to do a revision where I have 2 different stems from the same company. It just makes your life easier in terms of getting stock and inventory and the representative in the room. So that's something to consider. Sometimes there's no choice and you have to deal with different companies. But I think if you can have one company that can provide both options for you, that's usually better.
You mean in terms of the socket and the stem? That's what you mean?
No, I mean, even in the stem. So, as I said, if I were going into this case, I would probably have my case is different because at HSS, we have everything on the shelf. But most places, you have to call in advance. You have to get somebody there. It's much easier to call one person to be there than it is to call two. And if that one person can bring in two different designs, sometimes that's a much simpler option than calling in two different people.
Right. Okay. Right. Rajkumar?
Yep.
Yes, please.
Thanks, Anup. Good evening to everyone. My case is almost like reinforcing the points what Dr. Vijay has mentioned in his talk. And my case is more pertaining to the stem as well. But still, I would like to go through the case for everyone. This patient is a 46-year-old female, very short statured, female, thin built, bilateral dysplastic hip. And this is a Coxa valga, bilateral dysplastic. And also patient has got a fused hip in the lumbar spine as well. So obviously this patient needs a hip replacement. There is no doubt about it. And it's a Crowe type 3 and Arthroplasty is type B classification. And this patient had more pain on the both the sides. So we had to stage it and do it in 2 stages. So as everybody, we have discussed almost all the points here, and just to go through again and reinforcing the points. Difficulties on the acetabular side, again, is shallow acetabulum, deficient bone in the anterior, superior, and lateral part. The head is pushed laterally because of the medial osteophytes. So if you look at this, if you want to put the cup in the native acetabulum here, obviously you will have a lot of uncoverage of the cup and you will require bone grafter and metal augments, which was the one technique which was being done previously. But nowadays, high hip center helps a lot to avoid all those things. Difficulties in the femoral side, in this case, it's a Coxa valga, high neck shaft angle, and also more femoral anteversion and less femoral offset. And in this case, particularly, it's a narrow medullary canal. So all these things has to be taken into account before we plan for the surgery and be prepared with the implants appropriately. So this is a post-operative X-ray, 3 years down the line, a post-operative X-ray. And if you look at here, I have done a bilateral high hip center, one side a little higher than the other side, but almost within the allowed limits. And if you see the right side, I have used a bantam cup, 42 pinnacle size, and it was also discussed very much. Here, the most important point here is the 22 head size. We have only 2 sizes, so I have to be very careful in getting the offset and the stability correct. On the left side, I was able to get a 44 pinnacle cup with a 28 size head. Both the sides, I have used a S-ROM type of stem. This is the cup coverage, almost, and the cup is covered reasonably because of the high hip center. If it was a native acetabulum, then I had to use a bone grafting. So femoral side periprosthetic fracture, why this has happened? If you look at the sizes which I have used, both the sides, I had to use a 9 size stem, and this was the maximum I could get inside. And the right side, when I tried to go for if I need to upsize, then if I try to ream the femoral canal more, then I have to use a 11. We don't have a 10 size, then I have to use 11. That means my sleeve also has to be upsized. So that will be a big problem. And in this case, definitely I wouldn't have been able to get a bigger sleeve. So if I had gone for 11, so 9 size was the maximum. And I didn't want to ream more to get inside the sim. I know I had to ream line to line, but if I had to ream more, and then suddenly the distal stem becomes loose, then I have to upsize the sleeve. So that becomes a problem. So that was the difficulty I faced on the right side. Somehow on the left side, I was able to get away without any problem. So as here the chart mentions, so 9 stems, 9, 11, and 13. We don't have a 10, but every upsize of the stem, then we have to upsize the sleeve also. And the AP diameter also increases accordingly. So if you go for a 16D or a 14F, then the AP diameter of the sleeve also increases. So from 19, 21, 23. So that also makes it a difficult situation when we have a very, very small femur, where both proximal and in the distal portion. So maybe in this situation, a Wagner cone type of process would have been a better. This case was done 3 years back, but in this situation, if we do a preoperative thinking and planning, probably a Wagner cone type of processes, because we need a fixation in this point. So looking at, as Dr. Vijay was very nicely put into, that the Wagner offset is very, very low. It starts from 27.5 and it has got both low of 135 degree and also a high offset of 125 degree. And it goes in up to from 13 to 24. And also it has got 8 longitudinal ribs and the fins, which gets into the cortex. It cuts through the cortex and it gets a very good rotational stability. And the version also can, since it's a cylindrical stem, it can be rotated, the version can be rotated as we need according to the case. So this is an excellent stem for this kind of femur. And quickly, Dr. Amar very rightly discussed about the high hip center. There are very good literature support which says high hip center nowadays with an uncemented socket gives good results. Particularly a recent article which has been published in JO for bilateral high hip center. Overview of the conclusion is faster post-operative rehabilitation, similar gait parameters as with the anatomical reconstruction, and the gait pattern becomes similar. So bilateral high hip center is advisable if bilateral periacetabular bone insufficiency is there. So quickly on Coxa valga, in Coxa valga, if standard stem is used, what will happen? It increases the femoral offset and the abductor tension. So that is not good. Patient is not happy. So you should not try to use a standard stem like a Corel in a Coxa valga type of situation. So what you have to do, you have to try to use a smaller cup and medialize the cup, high femoral neck cut, head with a short neck and stem with a low offset. So this is what you have to keep it in mind when you are planning for a high Coxa valga type of situation. So to conclude quickly, this type of bilateral Coxa valga dysplastic hips, definitely, particularly in type 3, you have to have a modular system, either a SROM or a cone Wagner, and also keep in mind that the pinnacle bantam cup of 38, 40, and 42 is absolutely necessary, where it has a 22.2 head size. Thank you. So preoperative planning and anatomy, judicial reaming, proper placement of the cup, a high hip center at the correct level, and select the appropriate stem. Ceramic on poly, always don't try to use a ceramic on ceramic in these situations. All these will help in dysplasia. Thank you.
At which point did the fracture occur, Rajkumar?
While inserting the stem.
Yeah, so Rajkumar, that's more of reaming technique rather than choice of a stem. I mean,
No.
if you're reamed maybe 0.5 millimeter more, as advocated in SROM, maybe that wouldn't have happened. What do you think?
No, the point here is, again, I want to say, see that reaming, I know I reamed almost 0.5 more in this case, as it is needed for a stem. But in this situation, the only point here is, see, if you see this sleeve, it is almost, it is not fully sunken. It is, even though it is little protruding up. So if I had to ream little more and suddenly if I feel this stem is not holding, then I had to go for a 11 size stem. So that is where the situation comes. And if I go for a 11 size stem, definitely I couldn't have gotten the bigger sleeve, the next size sleeve.
So let's take some faculty point of view. Amar, I think Cavanella has reported that you put a prophylactic wire in the distal part before you insert the stem. What do you think of putting a prophylactic wire to prevent propagation of a fracture while insertion?
I do that much more often if I'm doing a true distal fitting stem. I think there's nothing wrong with that. I think you have to have a sense of your fit and your preparation. So do I think it's mandated? No. If I have any concern, I would do it. And so, the right answer is try not to crack the bone. And if that's what it's going to take, then that's fine.
Right. Suri, any other tips to prevent fracture during insertion? I mean, fracture of the stem, fracture of the distal femur. You have to unmute yourself, Suri.
Yeah, I agree. I think the circulage wires do work if you are suspicious, or use a bone clamp, reduction clamp to hold it during the time and go a millimeter at a time. not to rush through. If there's any sort of a cortical resistance, you should, I think, walk back, probably play the reamer one more time, and then get the stem in. Even if it is probably with a little concern whether we will lose the fixation. It never happens. I personally, in all this, the last reamer, that's why I prefer to use with the hand. That gives you an idea whether you're going to have difficulty or you're not going to have considerable difficulty.
Yeah, yes, Vijay, please, yes.
Yeah, I don't think, like Amar said, wiring in an SROM is, an option. When doing a truly diaphyseal fitting stem, Wagner, then of course, wiring is very mandatory, but not in this situation. Now, we again compare the Dors index. When the cortical thickness compared to the medullary canal is very high, then, your rules of, 1 millimeter more and all does not apply. Yeah. So you need to ream more. So you have to know the fit, as Amar said. You find it too tight, you need to ream 0.5 more. I mean, that's how it goes. So, so the cortical thickness, if it's more, you got to ream more. You can't apply the same yardstick for every patient, So you find it a lot of resistance, don't go, come out 0.5 more, then go in.
Yes, yes, Amar, anything to add?
Yeah, you can always back the sleeve or back the stem out, and sometimes you can ream through the sleeve one more time, or you can knock the sleeve out. That's the whole value of non-cemented fixation, is that you can take out these components and re-prepare, over-prepare, over-ream, so that, every time you hit it, it should advance a little bit, right? And if it's not, you hit it 5 times, it's not advancing, you have to make a decision. And usually in my case, it's take everything out, let's re-ream, and we start over.
Yeah. Right, Amar, in a case like that, with patient with spinal fusion, if this spinal fusion is right up to the lumbar area, we know that these patients are more prone to instability. Would you think of a dual mobility in this particular cases with the spinal fusion, or you would go with your standard components?
Yeah, I mean, I think we know now that the lumbosacral and pelvic relationships, and with these levels of fusions, there are many authors now that are proposing using dual mobility in these cases. I agree for the most part. If you're doing a subtrochanteric osteotomy, stability is not an issue because those are tight hips to reduce. But in these cases, if you're limited to a 22 millimeter head, it might not be a bad idea to think about it because I think she is at increased risk for dislocation.
All right. Any other panelist would like to add for spinal? Yes, for patients with spinal fusion. Yes, Rajkumar.
Yeah, like in this case, the one advantage was that the patient already had the spinal fusion surgery has been done. So perioperatively, you can decide. The problem comes if the patient is not already operated and it has got a very bad spine. Maybe after the surgery, if the patient is going to go for a fusion, then the problem comes. Yes. So that is where the situation comes. But here, fortunately, the patient has already underwent a spinal fusion, and it is a bilateral hip case. So where you can accordingly judge your stability on table and put the cup. So here, not much of a need for a dual mobility. Point number 1. And point number 2, I would like to ask Vijay, since he has spoken about very nicely about the stem selection. So in this case, if he was doing now, if there is, will he select a Cone Wagner?
This got a good flare, Rajkumar. So my first choice would be a SROM in this one. I would think so. Yeah.
Okay.
So the other point I want to make is in a spinal fusion, a 22 head, although you've done a great technique and you're confident of your spinopelvic indices, 22 head is risky. You have to think of, that's what I said in the first one, like this side, you can bring it a little down and expand the size of your cup. Quite possible. You can see the native head, it's not very small. The native head is quite big. So I would have brought it a little down, made my cup, at least I would have gone for a 28. 22 in these patients, the spinal fusion is a risky gambit.
But if you see the post here in this X-ray, there is some amount of uncoverage here. Even in this.
As Amar said, I would push 30% without a wink. I mean, that doesn't worry me at all.
Yeah, no. If you are going for a bigger cup, I am asking. So if
even for a bigger cup, I'll get probably 20% uncovered, but that doesn't worry me at all. The other parameters, for example, if this patient the dislocation, that's a big story to do that. Yeah.
Yes, Dr. Mohanty, there are questions from the audience?
No, for this patient, suppose this patient would have come before the spine surgery. You would have preferred a spine surgery first, then do the hip, or you do the hip first, then send the patient for spine surgery? What is the opinion of all the panel?
Maybe we can take a few quick opinions. Yeah, yes,
Amar.
Yeah, I mean, I usually will argue that you should do the hip first because that can often obviate the need for doing lumbar surgery. So that would be my recommendation. It's very rare that I recommend someone to get spine surgery first. I'm not worried about dislocation. I can manage that problem. So that's my opinion. Do hip surgery first.
Right. Maybe Dr. Sanjeev Jain can start sharing his screen, and if other panelists want to say something on that point. And in case the patient is planning or have to have a spinal surgery in future, then maybe you can choose a dual mobility in case the spine is going to get fused later on. Okay, Dr. Jain?
Yeah.
Yes, please.
So it's a wonderful seminar. I think every point is practically covered here. And I need to just present a case where I had an intraoperative fracture. This is 32 years old lady with type 4, the Crowe. And as usual, you see the X-ray. The canal was very, very narrow. Femoral canal was absolutely very narrow. This I did around 12 years back, in fact. This was the lateral X-ray. As usual, I'm going to run it a little faster. It's not going forward.
Click on the screen.
CT scan was done. And the main problem, as everybody has discussed about the challenges, which I'm not going to even talk about it. But the main problem, which what I had is here is a absolutely narrow canal. And to bring to head to the normal native acetabulum, naturally the femur was prepared first and subtrochanteric osteotomy was done. And then later on the socket was repaired. Of course, I did use the remaining head as a bulk graft and oriented socket properly. But I had an intraoperative femur fracture, which was basically after putting an stem. Sleeve was all right, and this was splinter here. And I had to wire it and keep the patient non-weight bearing. The distal fitting was good. There was no need to stabilize the osteotomy. I had to put a bone graft, and it healed. Everything went off well. And at the end of 5 years, this was the result. Now this patient is for the 12 years with the same kind of situation. So this was, I had a problem with the intraoperatively for fracture, which is just around the sleeve or just below the sleeve, you can say.
So Amar, that's worse, getting a proximal femur fracture than a distal femur fracture. So if you have a proximal femur fracture, Amar, what would you like to do? Like to change something or go ahead with what Dr. Sanjeev did?
Well, I mean, it depends what you have available, but I would certainly consider going distal in this situation, as opposed to staying with the SROM. But the narrow canal could make it extremely difficult to go distal. So, those are all limitations. I think sometimes you have to just do the best you can do, and you can limit their weight bearing. There are all sorts of things that you can do to try to, make it work. I will say that the other, criticism I have is, putting the cup too inferior.
That's right.
I mean, you put bulk allograft on top where you could have easily moved the cup up a little bit instead. But these are difficult cases, no question.
Yes, Vijay, something similar to what you had.
Yeah, because the cup has come so low down, the subtrochanteric segment that's removed has been quite big, and you can see the mismatch. You can see the mismatch there. Yeah. So like Amar said, bring the cup down below the two floor. Not a great idea. There's a lot of other consequences as well. Yeah. And you can see how the sleeve is so low down. All these have been used to compensate such a low cup. Instead, the cup is being a little higher, all these problems would not have occurred. Now, regarding the fracture of the proximal fragment, I would make a call depending on how rigid is my distal fixation. There are guys, who are SROM fanatics who would use a SROM even when they do ETO. But that all depends on how good is your distal fixation. If it's very solid, you found very hard to impact it in, it'll be fine. But if at all there is some kind of instability distally, this is a disaster. Yeah. So it all depends on how good is your distal fixation in the SROM.
And probably the success lies here because Dr. Sanjeev's stem distal fixation was pretty good.
Pretty good.
And
Yes,
that's why all this healed.
Yes.
Yeah.
Yes.
Suppose.
Yes,
Yeah.
Dr. Mohanty, yes, please.
There are two questions. Suppose in this case, the distal fixation is not very good. Then we could have changed the stem and we use a Wagner type where the distal fixation is good, correct?
Yes.
Correct.
Yes.
May not be a Wagner because Wagner starts very high, but there are other distal fitting stems which starts pretty low. So I would use a distal fitting stem which has got a smaller dimensions than the Wagner.
Okay.
Like
Vijay, like
the MRP Titan, for example. MRP Titan, that would be the ideal stem to use.
But there are not many,
which company is this?
Exactec.
But Vijay, is it possible to get all those stems on the table? You're planning a SROM, something cracks, and you don't get all of
the cortical index. You are here handling a very small stem. So when you have this, the cortex is as thick as the medullary canal. Here is a recipe for trouble. Oh yeah, you got to plan that accordingly. Yeah.
So as a primary choice, your stem would be what you mentioned and not a SROM. Is that right?
No. It'd be SROM. It would be SROM. No question, be an SROM. It'll be an SROM.
Okay.
A little different technique, but a backup plan would be such a stem. Yes.
All right. Yes, Dr. Mohanty.
Yeah, but my question is on the acetabular side. Then what we recommend that bulk allografts have got a not a very good outcome in the long term because of the absorption and all that. So what is the recommendation when to use bulk allografts?
Yeah,
and that also brings the curve. Yeah.
2020. Amar, when to use bulk allografts? 2020.
I almost never do.
I mean, sorry, bulk autograft.
Autograft.
Oh, yeah. Okay. Autograft. Suri, any role for autografts in 2020?
Very, very little. I have to think a lot now, I think. Unless, of course, it's an entirely lateral index, which is very vertical, and you don't get a very precarious fit. You still will get a fix in between the AP columns and then just augment a graft on the top like a flying buttress, like we do in the revisions. Because you have to put it. And over a time, it can remodel it. Can I just add to that one point that can come up?
Yes.
We are talking about lumbar spinal fusions. And
yes,
the
please.
in this case,
yes.
If the L5-S1 segment is not fused, and even if there is a limited mobility, it takes off a lot of concerns on the hip side in terms of the spinopelvic mechanics. So I think that is one point. Just because we have a posterior implant covering 2, 3, 4 segments, it's different. But if it is L5-S1 involved or also added in the fusion segment, then I think the ball game changes completely.
Correct.
So I think this is a point just to keep a watch on.
That's right. So basically the sacral slope, I mean, it fixes the spinopelvic junction. Yeah, that's right.
Anup?
Yes, please.
Yeah, just to add one more point at what Dr. Suri said, in the recent spine journal, which I discussed with my spine surgeon, and he showed me an article which very clearly they have published that in a review article, that if there is a dual problem, both spine and in the hip, now it is almost all better safe to do the spine first and then go ahead and do the hip. That is what, and they have published a very good this thing.
Yeah, but Rajkumar, it depends on the symptoms the patient has. I mean, if patient has got bilateral type 4,
both are symptomatic. If I'm talking about dual problem, both are symptomatic. Then they say better to do the spine first and then go ahead and do the hip.
All right. Okay. Yeah, great point. So, Dr. Sanjeev, you can stop sharing and Dr. Bhende can share his screen. And meanwhile, any other panelist want to make any other points?
Yeah, can I, Anup? Yeah.
Yes,
so,
yes, please.
Coming to the use of bulk allografts, I would echo what Amar said, no role if you are using non-simulated cups. But if you are a fanatic of simulated cups like the Wrightington group, you always have to use a bulk graft. But otherwise, non-simulated cups, in dysplasia, there is no indication today in 2020.
Great. Okay, so last case, Dr. Bhende. Yes.
Okay, I wanted to share one of my problems, complication which I created. There are many others I've created, but this is one of them. This was a patient which was 38-year-old female, which is a bank executive, quite active. She had a multiple surgeries done when she was between the age of 3, 4 or 5 year old. She didn't remember exactly what was happened. And this is how she was. She had a very hypoplastic hip on the right side, which was operated multiple times with the implant inside. And the whole side on the right was, because of maybe underuse, was hypoplastic. You can see that the whole pelvis is not as well developed as on the left side. Also the distal limb, the shaft of the femur, you can see is very narrow and significantly osteoporotic. And the entire leg length was little smaller, almost about 3-inch shortening was there. And she had started getting significant pain when she was walking. So that's the reason she came to us. If you can analyze the problem, the bones are quite thin and quite small. The bone has very limited bone stock in acetabulum. There is a fibrosis because of multiple previous surgeries, because of previous scarring. Exposure difficulties were there. Obviously, old implant had to be removed. And there was poor abductors. She had a significant abductor lurch when she was walking. And obviously, the shortening was there. So we wanted to go ahead with the surgery. We thought we can put a small cup and try to get the acetabular position little higher. We had taken a CT scan to assess exactly how much of the bone stock which is there, and whether what is the smallest cup I could put. And we thought that this was in 2006, that we might have to put a graft. Unfortunately, this is not the situation where you can have autograft from the patient because the head is long gone. So what we did was we used the iliac crest graft from the same side, put it on the superior part to get some hold there. We put up 2-3 screws, and we had a reasonably good cup which was holding reasonably well. We did a SROM implant, and I was very happy with the whole thing. And eventually we protected the leg. Patient was allowed to walk, and she was walking quite with a limp, but she was better off. The pain was gone. This was 2006. And then by 2009, this was a picture on the left side has turned to picture on the right side. You can see that the whole implant has become loose, and there was a significant osteolysis around it. There was sinking in, and you can see that the whole shaft also has become something like a viper effect, and it was moving mediolaterally and ballooning out laterally. So she was started getting pain again in the upper part of her thigh. So if you can see this, this was a picture in 2010 when she eventually agreed to undergo a second surgery and revision, because that's another issue. When we tell the people that you need a revision surgery, sometimes they are apprehensive. They don't immediately come up for operations. So she lost about a year in thinking about the surgery, and eventually she was ready. Now, if you can see, there is a huge amount of, this was a, where is that? Yeah. So the problem was, if you can see the analyze my primary surgery immediately post op X-ray, my subtrochanteric osteotomy was at a wrong position. It should never be at the level where my sleeve is there, and it should have been somewhere around there, about a centimeter below my hip. Second thing is this stem, if you see in a pre-op X-ray, was almost vertical. There was no flare, as Vijay has mentioned, proximally to allow that proximal sleeve to fit properly. So maybe that is the reason my sleeve wasn't fitting very well to begin with, and which I didn't realize at that point of time because I wasn't very accustomed to use SROM in 2006. And a third thing, if you can see the shaft, the distal part of the implant wasn't also filling the entire canal. So probably that also was not very well fitting. And I couldn't go to the bigger size because the sleeve was not, sleeve of bigger side would not have fit into the proximal part. He has mentioned the big, almost cylindrical vertical shaft. I didn't have these, Wagner implant at that point of time. And I thought it had worked very well, but eventually it failed. And this was the situation where there was significant osteolysis and implant being loose. The question is, at this point of time, what should I do? Any takers for this?
Yes, Amar.
If you
So,
can see here, the problem is, there is a metaphyseal widening almost at the level of the isthmus, and below that the cavity is ballooning out more. So the issue is that metaphyseal area, the diaphyseal area, and the distal part of the femur is significantly osteoporotic. It was the thin osteoporotic patient. You can see the supracondylar area, the bone is very thin.
So, Amar, what do you think really caused this problem? Let's take the panel into the loop. Yes, Amar. So, what do you think caused this, Amar?
Yeah, I mean, I think Harish said all the things. This was technical. The sleeve was probably too big. It was put in at the level of the osteotomy. Distal stem was probably undersized. So that's the reason why. But right now I want to see full length femurs so I can assess better how I can fix this.
I don't have it here, but there is no hidden surprise below that. I mean, it's a widening shaft. The lower end is almost near the isthmus.
So type 3B type of a defect.
You're running out of options. I'm probably going to end up considering doing a long cemented stem. That might be the best option.
What about modular stems which are recently available? The reclaim kind of stem, but
well, you need. That's why you need to see the distal femur. You need to see you need to have about 2 centimeters.
It's a
2 centimeters of scratch fit.
Harish, in this kind of a situation, what about the solution kind of a stem?
Yeah, distal fitting stem. Yeah. Harish, tell us how long is the stem extending now? Mid shaft, lower third. Where is this stem ending?
Right. The reasons, as Harish explained, are
see, this is the smallest stem.
Yeah.
This is a small stem going just at the level of the isthmus.
Yes.
I would revise with a distal fitting stem like a Wagner or a MRP Titan non-cemented fixation.
The another advantage with that MRP Titan is it has got a distal locking. Locking can be done with that as well.
Yeah, so, I think any locking fixation is good.
Yeah.
So,
reef type or
reef type of stem,
yeah, that's right.
I was just thinking.
Yeah, but the problem with all this stem.
Let's go one by one, please. Let's go one by one. Otherwise, the audience won't be able to. Yes. So let's go. Yeah.
The problem with all these stems is you have a very hypoplastic femur. The size 6 stem was barely fitting in the beam. So you cannot put a stem like reef, which is sizing from almost 12 to 14. It's impossible to put reef stem in many of the standard size patients in India. The issue with a long stem here, what we realize is in a
I think we have lost Dr. Bende.
Yeah, we discuss till he comes back.
Yeah, so Krishna, you want to say something? Krishna, you want to say something?
Rather than addressing what we have right now, I think we should look at why this went wrong in the first place. So this is the sort of pattern which is a post-septic sequelae with a combined supra-infratrochanteric shortening with proximal distal mismatch. And this is a recipe for disaster with SROM, not done properly. And this probably now retrospectively case for trochanteric osteotomy with sequential femoral shortening and then addressing. I may be wrong, but I want Dr. Vijay's opinion on that case. I think we must look at why it failed in the first place.
Right, Vijay. And the stem was undersized as well. If you really go back to
this is a typical sequence of events. I've got a few that I've done in my early cases, and also some referred to me. When you undersize the stem, typically what happens in a SROM, the sleeve is not big enough for it to have stability by itself. So unless you have additional stability with the stem, it's going to fail in this sequence of events. You'll have a ballooned out cortex, very typical sequence of an undersized stem, very classical of a SROM undersized stem, I would think. Yeah.
Vijay, this situation has been visible in the earlier used stems, the isoelastic total hip arthroplasty, which was started by the AO. And I have seen a few cases where the distal femur becomes really ballooned up, and some cases of Austen-Moore processes. So Harish has rightly mentioned that because there was a mismatch between the stem was lying loose in the canal and that's how it has been ballooned up so much.
So the tips of the SROM is to correctly size this. We learned the hard way. The reamer must take bone in the the interstices, so that you're really reaming. You must look at the reamer and see whether it's really reaming or not. And once you put the reamer in, you must lift the whole limb and the patient with that. These are all clues that tells you that you correctly size the FEMA. If in doubt, use a C-arm. If you
use a C-arm, that's right.
SROM, classical sequence of events.
Yeah, use a C-arm when in doubt. Yes, Dr. Bende, yes, please. What did you do? How did you manage then? Yes.
Well, there was no way I could put the distal part with a long stem non-cemented implant. The reason was the bone was very small, narrow. So I, as Amar has mentioned, decided to go for a cemented long stem implant. This was the long stem cemented, which we did. And it worked very well. It was in 2011. The X-ray now is 2019. It's almost about 8-9 years since the surgery. The patient is working reasonably well. She's able to walk quite well. She has gone back to her office. Basically, this was a bailout situation. My only worry now is, for the last 8-9 years, she is traveling by train in Bombay. She's able to go back to the work. The pain is gone. But what if she come back? She's just 52 today. It was a metalhead because it was a C-stem. C-stem has a 9/11 taper. I didn't have any ceramic option there. So I had to go for a 28 head, and it's a highly cross-linked poly. So I do not know how long it will last. I presume another 10 years maybe. By the time she is 60, maybe 62, 64, she will require a revision. The question is what then? Because the whole, if you can see the proximal part, it is the entire cement almost till the lower end.
That's right.
Yeah. How much bone is remaining down below the cement mantle?
You saw that X-ray? I'll show you. This X-ray of the knee, you can see the upper end is the end of a cement. Can you see that?
Yeah.
That's the end of a cement, and you can see that there is a cement restrictor. So there is only that much bone left below the implant.
Yeah.
So if you want to remove that and put a distally fixing stem, you wouldn't have one.
What?
Okay, maybe that's for the next webinar after a few years.
Can I add something here? Yeah.
Yes.
So how we have managed these cases is we have to do an ETO here. It's very important that you have an ETO because that will again help you to bone formation. And then you have your distal canal right in your hand. And we have these other distal fitting implants. Even if you get 3 centimeters, I'd be very happy. Distal fixation, ETO will form bone very nicely. And that's how we have managed all these cases, and they do very well. Yeah.
One point I would like to mention that the best part of cemented implant is you make a long stem ETO, the implant comes out without any problem. It is not stuck inside. There is no bone in growth, and you can easily remove the cement. And then inside you've got a nice osseous layer in which you can put any cement, any non-cemented, fully porous coated implant. You can wire around it, and if you keep it protected for a long enough time, it will heal. So revision of cemented stem is not as difficult as a fully grown non-cemented stem.
So
during that time, could you have used a reef stem? What Anup was talking, and
no, reef is too large a stem for this. Reef stem is too large for this bone. I have used reef stem, but they just won't go into this.
Dr. Bende, you have the type.
Reef is no chance. 23 diameter. It will not even go near it.
No, the distal diameter is 10.
Yes, Rajkumar. Yes.
Yeah. Just to, I know Dr. Bende mentioned that the patient refused the surgery, and just for the audience sake, the loose implant was sitting there for almost a year and a half.
That's correct.
That also has eaten away a lot of good bone, whatever available bone. Probably if the patient has accepted and if the surgery was done that time, probably we could have avoided the cemented stem and gone for a distal loading uncemented stem. Probably that would have also saved a lot of lot of bone there, because it was almost a year.
Okay, correct. So I think it's 7:15, gentlemen. Yes, please. Yes, sir. Yes, sir. Please.
Just looking at all this, I mean, STOM sort of solves a lot of situations. and some of the variants, the primary Wagner helps you. But I think probably it's also time to go a little beyond the SROMs. In a sense, we have to have independent control for the proximal sleeve and the distal diameter shaft. With the SROM, you're always committed. One mates only with the other one. You're not able to change at all. So there are certain designs that are coming out in the market, which gives you both this versatility. You prepare your distal, get it solid, and then adjust your sleeve according to the size of what the bone allows or the anatomy allows. I think.
Dr. Surya, are you talking about modular stems, other type of modular stems?
Again, stem in sleeves, some are modular, proximal modular, both.
So your hands are not tied with one stem and one sleeve, but you.
I think SROM serves most situations, but I think it's looking beyond. Probably it's also worthwhile.
Right. So we are towards the end of the webinar, and maybe Amar, parting shots for the younger colleagues when they're handling dysplasia. Your précis of the whole situation. Parting comments, Amar?
Yeah, I mean, I think recognizing where the good bone is, that was the initial point. I saw a few cases today where the cups were placed too inferior. So I would say that's one thing you really want to avoid. And if you're unsure, get an intraoperative x-ray. And then I think, having a good plan and then executing that plan is the way to do these operations successfully.
Great. Vijay, any other points that we might have missed during our discussions? Vijay, anything to add at the end?
No, I think we pretty much covered everything on both the sides. So no specific point to add. Thanks.
All right.
One thing here, exposure. There are some cases where you are not able to reduce the head, and there the abductors, you have released everything apart from ABD adductors. There you can do some pie crusting, some needle placement, or some few nicks in the abductors to lengthen the abductors. So that is the only point which is probably we have not discussed.
Some soft tissue release tips, yes. All right. Krishna, anything to add? Parting comments, and then we can hand over to Dr. Mohanty.
I think the entire topic has been extremely well discussed, but there are inherent variations to the different subtypes. So you must carefully look at the anatomy, whether it's a normal looking femur, excessively valgoid or overgrown femur, or a sort of a trochanteric overgrowth. So that sort of a differentiation needs to be made, and correct choice of implant and adequate planning and execution must be very carefully done to get a good outcome.
And Krishna, when would you do a reverse sleeve? When would you put the sleeve in the reverse direction? When would you do that?
So when I actually started off, so I was more enthusiastic about it, but now I hardly do any reverse sleeves because it will eat into the trochanter, and when you do a revision, then you're in a tight spot. But if you really have to sink it right in, and then you're not having any other option. So if you just hammer the sleeve in the correct direction, then sometimes it can cause a subtrochanteric fracture, as we've seen in some of the cases. So in these cases, it's a useful tip to reverse it and then push it in. It goes into the trochanter. We can get another 2-3 millimeters of sleeve seating, but I would not do it in the current practice.
Yeah, so somewhere where there is an osteotomy and the trochanter is lateralized and you can't, then you can reverse it. Rajkumar, parting comments?
Yeah,
yes, please.
Yeah, that's what I was about to make, that for a proximal osteotomy done in a childhood where the trochanter is almost laterally placed, then you have to reverse the sleeve. Otherwise,
that's the only indication.
That's the only indication. Yeah, that's the only indication. Looks great on the X-ray, but we should know when to do it and not be very enthusiastic, as Krishna rightly said, and find the right indication. Okay, so I think that we summarized everything very well, and thank you, everybody. And let me take this opportunity from the faculty side, Amar, to wish Senior Dr. Ranawat best of health and convey our regards and good wishes to him. And with that, let me hand over to Dr. Mohanty. Yes, please.
Well done,
thank
Anup.
you.
Great job.
Thank you. Thanks, Anup, for moderating this great session. And, dysplastic hip has been definitely a difficult situation for all the arthroplasty surgeons, and you have nicely moderated it. And we have covered everything from the socket side till on the femoral side as well. And special thanks to Amar for joining today and devoting his time. And also special thanks to Suri, Dr. Suryanarayan, who has been kind enough to join today also to show the subtrochanteric osteotomy video. Now let me declare about the next week webinar. It is on periprosthetic joint infection, a nightmare for all the arthroplasty surgeons. It will be held on the 29th May and Friday from same time 5 p.m. to 7 p.m. And we have guest faculty, Professor Javad Parvezi from Philadelphia, United States, and Professor Thurston Gerke from Endoclinic, Germany. So both of them are the World Authority on Infection. So we'll have a nice time next week. So I request all of you to join next week also in the periprosthetic joint webinar. I'll be convening that webinar. And for the time being, you stay safe, stay healthy as we are opening up from this COVID situation. Thank you, everybody. Have a nice evening.
Thank you very much. Stay safe. Thank you.
Everybody.
Now we'll stop the live streaming and have a little informal chat.